Imagine you're sitting in a surgeon's chair, completely numb,
Right, totally no.
and they make an incision into your skin, but like not a single drop of blood appears.
It looks like absolute magic.
It really does. But the crazy thing is, the exact same drug creating that perfect bloodless illusion during the procedure is the one that could cause you to, bleed profusely hours after you've been stitched up and sent home.
Yeah, it's the ultimate double-edged sword in clinical pharmacology. I mean, we rely on it so heavily, but it demands just an intense amount of respect from anyone wielding a syringe.
Okay, let's unpack this because we usually think of epinephrine driving our systemic fight or flight response, right?
Oh, exactly. The heart-pounding, pupil-dilating adrenaline rush.
Right. But weaponizing it locally, like mixing it into a simple numbing shot of lidocaine, totally changes its utility.
Is a completely different application.
It really is. So today we're doing a deep dive into how localized epinephrine completely transforms what doctors can see during a procedure and the honestly highly surprising ways it alters your post-procedure bruising and bleeding.
It's a wild mechanism.
It really is. So whether you're prepping for a dental visit, maybe some cosmetic work, or you just have this insatiable curiosity about how your body's plumbing actually works, this is going to entirely change how you view a simple numbing shot.
Absolutely. Because when you take that stress hormone, adrenaline, and you confine it to a tiny patch of tissue, you're fundamentally altering the local vascular network.
So how does it actually do that?
Well, epinephrine is a remarkably powerful vasoconstrictor. So when it's injected, it binds directly to alpha-1 receptors on the walls of your blood vessels.
Okay, alpha-1 receptors.
Right. Think of those receptors as a microscopic command center for the smooth muscle surrounding the vessel.
Oh, gotcha.
When epinephrine hits them, that muscle basically spasms and just clamps the vessel shut.
So it's essentially a chemical tourniquet.
Ye-
But, I mean, why do we even want that? If I'm getting a cavity filled, I just want the tooth numb. Why mess with my blood vessels?
For two massive reasons, really. First, it keeps the numbing medicine exactly where the clinician put it.
Oh, because otherwise it would just wash away.
Right. If your blood vessels were wide open, the normal blood flow would just wash the lidocaine away into your systemic circulation.
Yeah, and then you'd feel the drill.
Which nobody wants. The numbness would wear off in minutes. So by clamping the vessels, the epinephrine traps the anesthetic in that local tissue, extending your pain relief significantly.
Which is obviously a good thing. And it essentially pauses the bleeding, right? Which brings us to the visual aspect of this whole thing.
Yeah, the visualization.
Because I was reading up on how this affects cosmetic procedures, and it's wild how clinicians use this chemical clamping as a literal map on the face.
Well, visualization is arguably just as important as pain management for the doctor. When epinephrine restricts that local blood flow, the overlying skin undergoes a process called blanching.
Blanching, okay.
Yeah, the tissue turns pale, or sometimes stark white, because the blood has been temporarily squeezed out of those superficial capillaries.
I found that especially fascinating with Botox or BTXA injections.
Oh, absolutely.
Because Botox takes days to actually paralyze the target muscle, right? The doctor injects it and nothing happens immediately.
Right, they're essentially flying blind.
Yeah. They're just hoping they hit the right spot and didn't, drift into a muscle that controls your eyelid.
Precisely. But when they use a formulation that's reconstituted with epinephrine, that instant blanching on the skin acts as immediate, real-time visual feedback.
It gives them a border.
Exactly. It provides a visible border showing the exact geographic extent of where the fluid has diffused into the tissue.
It's like drawing a map on the skin with invisible ink that suddenly turns white.
That's a great way to put it.
It shows you exactly where the drug has migrated. But, I have to push back a little here.
Sure.
Creating a completely bloodless field seems inherently unnatural. Doesn't the human tissue need that continuous blood flow to survive?
You would think so.
Right. Aren't we risking starving the cells of oxygen just to get a clear view?
What's fascinating here is that this temporary calculated starvation is exactly the point. And the tissues can handle it perfectly fine for the duration of a typical surgery.
Wow, really?
Yeah. The clinical literature details how crucial this is in intense, highly vascular areas. Take a total knee arthroplasty, for example.
A full knee replacement.
Now-
Bone bleeds a lot when you cut into it.
Oh, profusely. It's
Yeah.
essentially a porous sponge filled with blood.
Yikes.
Yeah. So during those surgeries, surgeons will actually pack epinephrine-soaked gauzes directly onto the cut bone,
Wait, right onto the bone.
directly on it. This vasoconstriction provides what surgeons call ideal bloodless visualization.
Okay, that makes sense.
Think about it, if you're a plumber trying to fix a microscopic crack in a pipe, you can't do it while water is just gushing in your face.
No, you definitely can't.
The chemical tourniquet completely removes the visual obstruction of pooling blood, so the surgeon can actually see the microscopic structures they're trying to repair.
Okay, I get that. That makes perfect sense for the duration of the surgery. But a tourniquet is only useful until you take it off.
Right.
If we're temporarily clamping all these vessels shut, what happens when the drug wears off? Which brings us to the real mystery here.
The rebound effect.
Exactly. If epinephrine is so incredible at stopping bleeding during the procedure, why does it have this reputation for causing severe post-procedure bruising and massive hematomas later on?
To understand that, we really have to look closely at the timeline of the wearing off phenomena.
Okay, walk me through it.
Depending on the concentration used and, the specific area of the body, that intense vasoconstriction can last anywhere from 30 minutes to up to 10 hours.
10 hours, while the surgery itself might only take an hour.
Exactly. So imagine a surgeon performing a minor excision.
Right.
During that hour, their scalpel might accidentally nick a tiny artery.
Which happens.
All the time. Normally, that artery would bleed. The surgeon would spot it and they'd cauterize it or tie it off.
Right.
But because the epinephrine has that vessel clamped tightly shut, it doesn't bleed.
So the surgeon looks down, sees a perfectly clean, dry surgical field, and thinks they've achieved perfect hemostasis.
They assume the tissue is secure. Yeah.
Mm.
And they stitch the wound closed.
Wow. So it's basically giving the surgeon a false sense of security, like sweeping dust under the rug, knowing full well the rug is going to get pulled away later.
That is the perfect way to visualize it, because eventually the drug metabolizes. The alpha-1 receptor activation fades.
And then what?
And what follows is a relative post-operative vasodilation. The blood vessels spring back open, sometimes dilating even wider than their normal resting state.
Oh, no.
Yeah, that little nicked artery, which was previously masked by the drug, it suddenly opens up and starts pumping blood into a surgical space that is now completely stitched shut.
There was a really vivid case study in the sources that perfectly illustrates this.
The basal cell carcinoma case.
Yeah. So an elderly man went into a clinic to have a basal cell carcinoma, a type of skin cancer removed from his shoulder, right over the trapezius muscle.
A very common procedure.
Right. And the clinical notes said the surgery went flawlessly, completely dry field, zero complications. They stitched him up and sent him on his way.
And then the biological timeline caught up with him.
Exactly. About 45 minutes after he left the clinic, the localized epinephrine wore off.
And he had to rush back.
He had to rush back because he had profuse active arterial bleeding expanding right beneath his closed wound.
It's terrifying when that happens.
They literally had to cut his fresh stitches open, dig around to find the active arterial bleed that had been totally invisible during the surgery, and manually tie the vessel off.
Because the drug masked the trauma until the patient was already out the door.
Exactly. And if he hadn't come back, all that pressure would have just built up into a massive expanding hematoma under his skin.
It's a huge risk.
But I'm trying to square that story with regular surgical practice, though. I mean, if the rug gets pulled, like we said, and it causes this hidden bleeding, why do surgeons still use it so aggressively in massive procedures like facelifts?
It seems counterintuitive.
It does. Doesn't that just guarantee a postoperative disaster?
Well, that's the exact paradox. Researchers have spent years untangling. When you look at the broader clinical data, the outcomes seem entirely contradictory until you break down the physical mechanics of the specific procedures.
Give me an example.
For instance, studies on tumescent phlebectomy, which is the surgical removal of superficial veins.
Yep.
They show a 0% rate of hematoma when epinephrine is used.
0.
0%. But then you look at facelifts, cervicofacial rhinodectomies, and the data completely flips.
Right.
The risk of postoperative hematomas is significantly higher when epinephrine is used. Why the wild swing? It all comes down to the interaction between the chemical timeline and the physical environment the surgeon creates. One of the most striking examples of this clash was a 3-year retrospective study on patients with severe stage 3 and 4 pressure ulcers.
Oh, right. These patients were undergoing surgical debridement, basically cutting away the dead tissue so the ulcer could finally heal.
Yes, and standard protocol for these severe wounds is to follow the surgery with negative pressure wound therapy, or NPWT.
So they seal the wound and apply a medical vacuum to it.
Exactly. It applies a continuous pressure of about 100 to 125 millimeters of mercury.
Which is pretty strong.
It is. The vacuum draws out excess fluid and physically stimulates the tissue to promote blood flow and healing. But the study revealed something really alarming.
Which was?
When epinephrine was used during the initial debridement surgery, those patients experienced a nearly 32% higher rate of bleeding complications once the vacuum was applied.
A 32% jump is massive. What is the vacuum doing to those clamped vessels?
If we connect this to the bigger picture, it's a timing trap. The debridement surgery is relatively quick, usually under 2 hours.
Okay.
But remember, the epinephrine's vasoconstrictive grip lasts 4 to 10 hours.
Right.
So they finish cutting, they seal the wound, and they turn on this powerful mechanical vacuum while the blood vessels are still chemically clamped shut.
Oh, I see where this is going.
The patient goes back to their room. 4 or 5 hours pass. The epinephrine finally wears off, and the blood vessels naturally dilate.
And the vacuum is still running.
Exactly. But now they aren't just springing back open naturally. They're being actively sucked on by a 125 millimeter of mercury vacuum.
It's literally forcefully extracting the blood from the newly opened pipes.
The complication descriptions in the literature are intense. The sheer volume of blood pulled from these newly unmasked vessels would rapidly clot and actually block the drainage tubes.
Wow.
The resulting hematomas would physically break the adhesive seals of the vacuum dressing. It caused absolute chaos for the recovery nurses.
I can imagine.
The clinical trend was so clear that the authors suggested rethinking epinephrine use entirely in cases where heavy negative pressure therapy would be applied immediately after.
So it's not that the epinephrine is failing, it's actually working too well for too long and hiding the structural reality of the tissue.
Precisely.
And when you add a mechanical vacuum to a suddenly open pipe, you get a flood. Which makes sense for the facelifts too, right?
Oh, definitely.
Because you have this massive area of dissected tissue under the skin. If it's all masked by epinephrine, the surgeon can't see the dozens of tiny bleeding vessels to cauterize them.
And when the drug wears off at home,
All those tiny unsealed vessels open simultaneously under the facial skin, causing massive bruising.
yes, the delayed, synchronized bleeding event.
So how do we mitigate this? I mean, we can't abandon epinephrine. The pain management and the bloodless visual field are way too critical.
Right, we need it.
So how does modern medicine navigate this delayed bruising risk?
One of the most elegant solutions developed is the tumescent technique.
Here's where it gets really interesting, because I've seen this referenced in liposuction and other large area skin procedures.
Yes, exactly.
Instead of giving the patient a standard concentrated numbing shot, they use massive volumes of incredibly dilute epinephrine. We're talking dilutions of 1 part epinephrine to 1 million parts saline.
It sounds extreme.
Wait, hold on. If you're pumping 1 million parts saline to 1 part epinephrine, isn't that just watering it down to the point of being completely useless?
You would think so, but it's a brilliant physiological workaround. Tumescent literally means swollen and firm.
Okay.
By pumping a massive volume of this highly dilute fluid into the subcutaneous fat, you are physically swelling the tissues with hydrostatic pressure.
So the physical pressure of the fluid itself is compressing the blood vessels from the outside?
Yes, exactly. It creates a firm, expanded plane that makes surgical dissection much easier and mechanically reduces bleeding.
That's clever.
But chemically, that extreme dilution is where the magic is. It allows the surgeon to spread the chemical tourniquet safely over a huge surface area like the entire abdomen or thighs.
Because if they use the concentrated stuff, it would be dangerous.
Very. But because it's so incredibly dilute, the systemic absorption into the bloodstream is painfully slow.
Which means you get the localized bloodlessness, but you don't get the crazy heart palpitations or blood pressure spikes you'd normally get if you injected a concentrated dose of adrenaline over a large area.
Exactly. It safely maximizes the local benefits while minimizing the systemic risks. And, this better understanding of dilution has actually overturned some major long-standing medical dogmas.
Like the fingers and toes rule.
Oh, the classic.
Right. For decades, every medical student was taught a strict rule. Never, ever use epinephrine in the fingers, toes, nose, or ears.
The infamous end artery myth.
Yeah. The fear was that these appendages are supplied by single terminal arteries without much collateral or backup blood flow, right?
That was the theory.
So the prevailing dogma stated that if you injected a powerful vasoconstrictor into a finger, the blood supply would be cut off so completely and for so long that the tissue would literally die. Necrosis.
Yeah. That was what everyone was taught.
That sounds absolutely terrifying. Imagine going in to get an ingrown toenail removed and losing the toe because of the numbing shot.
It does sound terrifying, which is why the rule persisted for so long. But recent comprehensive medical reviews have entirely debunked this myth.
Really? Entirely?
Yeah. It turns out that old fear of inevitable gangrene was largely based on historical cases from the early 20th century.
Oh, like really old data.
Exactly. Back then, they used older, highly acidic formulations of anesthetics, or physical tourniquets were mistakenly left on for hours. They essentially blamed the epinephrine for tissue damage caused by other factors.
So what does the modern data actually show?
It shows that using properly dilute epinephrine, usually a 1 to 100,000 or 1 to 200,000 concentration in the digits, is highly safe. In fact, it's often beneficial because it actively prevents the massive, throbbing, bruising, and swelling that usually accompanies finger injuries.
But are there any exceptions? I assume you wouldn't use it on just anyone.
There are caveats, of course. You still avoid it in patients with a pre-existing vasospastic condition, like Raynaud's disease.
Where their blood vessels already constrict abnormally on their own.
Right, aggressively on their own. But for the general population, the chemical tourniquet is perfectly safe for fingers and toes.
And even if a doctor does get concerned, say they do a nerve block on a finger and it stays stark white for a little too long, they aren't just sitting there helplessly waiting for it to wear off, right?
No, not at all.
They actually have a backup plan now.
Yes, modern medicine has a direct chemical antidote called phentolamine. It's an alpha blocker.
So if epinephrine is the drug pressing the constrict button on that alpha-1 receptor command center, phentolamine is the drug that basically pushes epinephrine out of the chair and hits the release button.
That's exactly how it works. It competitively blocks the alpha receptors.
So they just inject it.
Yeah, if a clinician sees sustained, complete blanching that concerns them, they simply inject dilute phentolamine directly into that same space.
And it just undoes it.
It immediately reverses the epinephrine's effect. The smooth muscle relaxes, the blood vessels dilate, and pink, healthy blood flow is restored to the tissue almost instantly.
It is quite literally a chemical undo button.
It really is.
That's incredible. So considering everything we've talked about, the masking effect, the delayed bleeding, the chemical undo buttons, what does this all mean for you, the listener, right now?
It's all about post-op care.
Exactly. The next time you have a minor procedure and the doctor hands you a sheet of postoperative care instructions, I want you to pay close attention to it.
Don't just toss it in the trash.
Right. When they tell you to apply ice packs, keep your head elevated and strictly limit your physical activity for 48 hours. That isn't just generic, one-size-fits-all medical advice.
Not at all. Those instructions are specifically engineered to combat the exact physiological window we've been discussing.
The ice packs aren't just for comfort, right? They are causing a physical, cold-induced vasoconstriction to seamlessly replace the chemical vasoconstriction that is slowly wearing off.
Exactly.
Keeping your heart rate down by resting ensures you aren't actively pumping high-pressure blood into those newly dilated, previously masked vessels.
You're managing the pressure.
You are essentially stepping in to manually manage your body's plumbing right at the critical moment when the epinephrine leaves your system and your blood vessels spring back to life.
Knowledge really is most valuable when it's understood and applied. Understanding this mechanism completely removes the mystery from your recovery period.
It really does.
The next time you're sitting in a dentist's chair or a dermatologist's office and you see your skin turn pale white around the injection site, you won't just see a random side effect.
You'll know what's happening.
You'll know exactly the microscopic, receptor-level tug-of-war happening within your blood vessels to keep you numb, keep the field clear, and keep you safe.
It really is a chemical tool of incredible utility. Epinephrine gives doctors a perfectly mapped, completely bloodless visual field to perform incredibly delicate work.
It's indispensable.
But as we've seen from the expanding hematomas and the wound vacuum traps, it's also a master of disguise when it comes to vascular trauma.
You have to respect the rebound.
Exactly. But before we wrap up this deep dive, there is one final lingering question I want to leave you with based on all these mechanics we've just explored.
Okay, let's hear it.
We have spent this entire time talking about synthetic epinephrine drawn from a vial and injected by a doctor to selectively control your bleeding and visualization.
The highly controlled clinical application of the hormone. Wow.
Right. But we know our own bodies naturally produce massive amounts of endogenous epinephrine during moments of fear, anxiety, or stress.
Our built-in fight-or-flight response.
Exactly. So consider this. Could simply being absolutely terrified while sitting in the waiting room theoretically cause enough natural systemic vasoconstriction to alter how you bleed during a procedure?
Oh, wow.
And more importantly, when you finally get home, let out a massive sigh of relief, and your natural adrenaline drops, could that sudden systemic relaxation cause a natural rebound vasodilation, completely changing how you bruise after the fact?
That is a fascinating thought.
It really makes you wonder just how much our own state of mind is actively rewriting our surgical outcomes.